I can't believe how much snow Nashville and Knoxville got. Our office is in Knoxville, and they were saying they got 10 inches, which is just, I mean, they're going to be locked in for days.
Yeah.
When you're in the South and it snows, it shuts everything down.
Oh my gosh. No doubt.
All right, hello, everybody. We are today, this is the January 2024 Power Talk with good people. And I'm going to let Kane take it from here for now. And
All right. Why don't we just give it a couple more minutes? I see a lot of familiar faces coming in. Hey, Wayne, Eric, Travis Staples. I'm sure you're getting a little bit of snow where you are, my friend. We were just talking snow.
You know what, Kane, I gotta tell you, I wish I was down in Florida with Jesse right now. Ain't gonna lie.
I was just down there, Jesse. It was beautiful.
You're in which Dakota, Travis? Remind me.
South Dakota.
South Dakota.
I'm in DC. We have like 5 inches of snow right now.
I would dream for 5 inches of snow right now. Okay.
And I'm jealous of all you guys with your snow because I didn't grow up in Florida. So I miss it and I love it. When I see the whiteouts, I'm like, oh my God, it's so nostalgic. And then today here, it's like, oh, it's 71 degrees. I'm like,
I feel like I just want to punch Jesse right now. I ain't gonna lie.
I'm telling you, man, this blue sky gets so old. You're like, ugh. Just
No, no, it doesn't. I assure you of that.
I forgot you still have your place here. What are you talking about? Come on down.
Yeah, we still have our place down there.
Yeah.
So-
Speaking of that, you need to come down. We need to schedule a round of golf or something.
Yeah, I think I'm gonna be down the first week of April, actually.
Say when, dude. I'm down like a fat kid on a seesaw.
Okay.
Sounds like a plan. All right, we'll give it just a couple more minutes. How's it for you, Eric, in Denver? Sunny and warm?
Yeah, the sun came back out. It was, only like 15 below last night, but came back out today. It'll melt.
Oh man, it does melt quick up there. Mr. Scanlon, how are you doing? Fresh in from another win last night. Tampa Bay.
The big win.
Still got some peeps coming in. We'll just hold tight for just another minute or two.
Sorry, Kane. Yeah, big one yesterday.
Big one.
Yep.
Exciting year. Out of nowhere.
Since they only thought we were going to win maybe 4 to 5 games absolutely tops, I'm ecstatic.
Yes.
I have a bad feeling that Detroit's going to punch us in the mouth, but I'm happy that we got this far and that we did what we did to the Eagles.
Hey, Greg. How we doing?
Always glad when the Eagles lose. And I'm from there.
Hey, Kane, I got to drop at 3:30.
Okay. We're just waiting for just a couple more people.
Hi, Ron. Good to see your face.
Good to see you, Karen. How are you?
Good.
Hi, everyone.
Nice to see you, sir. Thanks for joining.
Sure. I saw Karen's name. I said I have to jump on board.
Flattery.
You know.
Love it.
I'm going to freshen up. I'll be right back.
One more minute. We're going to kick it off.
Kane, do we have anybody within Good People who's focused on insurance?
Assured Partners.
Assured Partners?
Yep. So
What kind,
Seth,
of, what kind of insurance?
I think they do it all. I think that's why Seth and Joey partnered with those guys. I'll connect you. I'll shoot you an email.
Okay, thank you.
Of course.
I'm sure I should have known that, but there's a lot of things I should have known that I don't know.
Yeah, no worries. I'll send it your way.
Okay.
All right, we're just about at 5 after. So we've got this thing recorded for the folks that are running a few minutes behind. So we're gonna kick this thing off and start the January 2024 edition of Power Talks, where good people connect. Thank you for everyone for joining us today. that we have a special one kicking off the new year. One of our major sponsors within Team Good People is Functional Pathways. And I would like to introduce you to, if you don't already know, Meg Laporte, a VIP Team Good People member. She's going to give us a few instructions and formal introductions, but thank you, Meg.
Thank you. Hello, everybody. Just like to ask that you keep your microphones on mute during the discussion, and you can put questions in the chat and ask at the end, near the end, and probably throughout too, if possible, and just have to remember to unmute it when you do. It's just helpful for everyone to not have too much background noise. So without further ado, I'd like to introduce our presenters today. They are Karen Welsh, who is Vice President of Clinical and Reimbursement at Functional Pathways, and Chris Sneed, who is Vice President of Business Development. So take it away, guys.
Yeah, thanks, Meg. Good afternoon, guys. I see a lot of friendly faces, folks that I know, and Rich and Jesse and a lot of you guys. I appreciate you jumping on today. We're excited to be on the first Power Talk of the year. I was like, do we need to wear like tank tops for this? Like, how much power are we going to show here, Karen? But I think we'll just roll with what we got. You know, we're excited to be part of Good People Network. You know, had a chance to meet Kane, gosh, probably 2 years ago, Kane, up in DC, and we finally figured something out last year to work together and be a part of your network. So we're really excited about it. We're going to be talking about, you know, things that, gosh, just about every prospect that we talked about in the market is concerned right now with reimbursement, with MDS changes. How do we improve our quality measures? I know there's a lot of business partners on the call today, along with, you know, some operators as well. So we'll try to tailor what we talk about. So even if you're a business partner, you can kind of come away with a few nuggets when you're out in the field and you hear things. But I'm our Vice President of Business Development, been with the company 3 years, been in the industry for 18 to 20 or so in other capacities. You know, if you don't know much about Functional Pathways, we're a privately held therapy company for 29 years. We're based in Knoxville, Tennessee, where they just got 10 inches of snow yesterday, and they're pretty much will be shut down for weeks. So I do not live there, thankfully, but again, excited to be here, and I'll turn it over to Karen so you can introduce yourself.
Great, thanks, Chris, and thanks for having us here today. Again, Karen Welsh, and I'm the VP of Clinical and Reimbursement Excellence at Functional Pathways for the last 5 years. Speech therapist by trade for over 30 years, but have been in the industry since I was 15. So basically 5 years ago, right? But I started out as a CNA in a little privately owned nursing home in Pennsylvania and have never looked back. This population is my passion and my calling, and it is truly an honor and a blessing to work with those without whom we would not be here. So really looking forward to the conversation today, to just talking through any concerns or topics or anything that you have that you'd like me to answer questions about, or Chris. I am all things reimbursement. I am RAC certified advanced. So I'm one of those weirdo people that loves the MDS and fall asleep with it at night, which is kind of what you have to do to keep up with nowadays, right? And if you want some leisure reading to be able to help yourself fall asleep more quickly, go to the MDS manual. It's a perfect way to do that, but really appreciate the time today.
All right. Well, Kane,
Thank you,
I know you've got some questions from folks that have sent them over to you, so maybe we start there.
Absolutely. Thank you, Chris. I was just pulling those up. So the first one that I got from a handful of people was, how can communities ensure success with the recent MDS changes?
Whew, that's a big one.
Go
We
on.
had the largest MDS changes since PDPM went into effect in '98 this year in 2023. So October 1 was a big, huge change year for us for 2023 in being able to implement GG for all payers and able to increase the social determinants of health. So lots and lots of different changes around the MDS, as I'm sure you all are aware. I think the biggest thing for making sure your teams understand is ensuring that you have that MDS coordinator trained up to the best of their ability. I know one of the things we do at Functional Pathways is we offer an MDS boot camp by our RAC certified people if they don't want to go through ANAC. Although I do always recommend that someone in the community is a member of the American Association of Nurse Assessment Coordinators. Very important. They are the ones that keep up with everything, and certainly I do as well, but they have a huge breadth of experience and contacts and, you know, touching base with CMS, touching base with the states, and understanding all the changes with the Medicaid piece, which is also a big piece that is changing with the MDS, moving away from the other state required assessment and all of those things, but really making sure that your team understands the importance of the MDS, and not just your MDS coordinators and the people that are filling out the MDS, but those that are responsible for the documentation to support the MDS. And what we're seeing with the audits and the RAC audits and the TPEs that are coming out, especially since CMS designated the max to do 5 chart audits for every single community, which, by the way, is not happening. The max said, nope, not doing it. We're going to pinpoint instead of doing all of them. But making sure your CNAs and your nursing staff, even your housekeeping and maintenance, understand what you're looking for from a documentation perspective, because it's all hands on deck, right? We know that staffing is a challenge. So the more people you can have looking at those residents and patients and reporting what's happening with them, the more successful you're going to be around the support of documentation for those residents, so that you get reimbursed for all of the services that you provide. No more, but no less. So I would say, you know, probably the best way to ensure that success first is education, right? Making sure that everyone that's touching the MDS understands the rules. And there are a lot. It's like a 900-page document that you have to memorize and, you know, answer all the questions and make sure you're not cheating or gray areas or anything like that around the MDS. But it's a lot. So expecting your MDS coordinator to be the only keeper of that knowledge, probably not the best way to go. Make sure you have somebody, like for us, all of our leadership from the ops and clinical perspective are RAC certified, because we understand the importance of the MDS and what that brings, not only for reimbursement, but also for that clinical and quality measure perspective as well.
Yeah, good point, Karen, and good points. And I'll just say, just kind of from a business development perspective, reimbursement is such a hot topic, as you guys know. I mean, it's you know, everything that I read from Leading Age, everything I read from ACA, it's always just talks about razor thin margins and the skilled side. And so, as Karen mentioned, you know, getting the reimbursement is so critical. And, you know, the MDS, and Karen, you can probably speak to it. I mean, if you got a new MDS person and they miss a digit here or there, I mean, you're not going to be reimbursed, and it's going to cause issues with vendors as far as payment and everything else down the line if it takes, you know, a month or two to get reimbursed. So it's such a hot topic, and I think that's where, you know, when you're partnering with a therapy company or any other company that can impact that, you really just look for that true partnership.
Right. And that kind of goes back to everything I mentioned too about the documentation. When you look at reimbursement and you think, gosh, if I don't document, for example, shortness of breath while lying flat at any time during that look back period, that could potentially be up to $75 to $90 per day, depending where you are, rural or urban, in your reimbursement, just by missing that one thing that we're actually taking care of. We're rolling the head of the bed up for the resident. We're propping pillows behind them. All of those things that we're providing care for and having to do extra assessment for is so important. But again, reimbursement is about no more, but certainly no less, right? We want it to be exactly on the dollar. And I think one of the things we talk about too, when we talk to prospects or even our own clients about reimbursement, if your MDS is accurate, there's a lot of people out there talking about rates and, you know, we can increase your rate, we can do better for your reimbursement. But if you're documenting exactly what's happening with the resident, the only way at that point that you can then change your reimbursement is to change your patient mix and have them be more critical. And we know during staffing crunches that we've been having for quite a while now, that taking more critical patients isn't always the best thing, because then your quality measures start to go down, your value-based purchasing for the rehospitalization piece, all-cause readmission starts to go down, and all the other pieces may start to fall apart. So I think it's important to understand for operators what goes into that reimbursement piece, right? It's not just we can snap our fingers and increase the reimbursement. You've got to look at your patient makeup and the acuity of the residents that you're admitting, because if you don't want to admit those higher acuity, your rate's not going to be nearly as high, which is actually a good thing under PDPM. For us, it's no longer just therapy based.
Karen, can you expand on that, the PDPM part of it, and why it's now, how that is now a good thing under in that context?
Sure. So for PDPM, it is the patient-driven payment model. There's a bright idea, right? We make everything we do directed at the patient. Whew, love it. And I'm a therapist saying RUGs was never a good idea. We basically had 2 doses under RUGs, which was 720 minutes and 500 minutes. And I can tell you, as a prior director of rehab, having somebody run down the hall to get an extra 5 minutes was, I mean, what was the purpose of that? It's got to be power punching those treatments and really focusing on the specific resident needs. And you can't convince me that every single resident needed either 720 or 500 with all the different comorbidities that we have. And all the different, whether you're looking at age, sex, comorbidities, primary reason for SNF admit, everybody's going to need something a little different. So PDPM has actually opened us up for that. So it's no longer just about the number of therapy minutes that you deliver. We have all 5 buckets now. So PTOT, speech, nursing, and then the NTA. So it's kind of refreshing, really, to be able to look at the holistic resident and then figure out what they really truly need. And one of the things that we've done is we've created our own predictive analytics that, based on lots and lots of MDSs, almost, I think, close to 700,000 different MDSs and data points, figure out the best way to approach therapy for our residents. How do we give exactly what they need to achieve their goals? Again, same concept as reimbursement, no more, but no less. What is the exact amount? And I think it's been a challenge for the therapy world because, again, we were moving from that 720 and 500, and we were all in that mindset for 22 years. So changing that to, oh my gosh, now we actually get to figure out what the patient actually needs. And I think we're still in process of that, especially through the pandemic when we were just trying to hold it all together, right? So to me, that's the biggest difference between what we used to do and now PDPM is the ability to truly focus on what the resident brings to that table and what's really going on with them and that true resident-centered care.
I think Jesse had a question in the chat box.
Sure.
Is there a specific method for MDS as in electronic versus paper?
Oh, we don't do paper anymore. Thank goodness. Although I think some people, depending, if you ask some of the older MDS coordinators that have been around prior to 1998, they may wish to go back to paper, but it is all electronic. Now, what some systems are doing is they're starting to implement some of the AI pieces where you have scrubbers that look through that medical record and they're actually able to pick out keywords. But that doesn't take away from the work for the rest of the MDS team because you still have to validate that those words that might be in the medical record are truly affecting that resident now. If you talk about active diagnoses, prior surgical procedures, all of those kind of things. So the recording of it is all electronic. And then there's actually some really cool systems out there from a scrubbing perspective that not only scrub the MDS to look at, okay, if you coded this and you coded this, that doesn't make sense. You can't have those two things together. So make sure you're looking at that and ensuring that your documentation are consistent with each other. And then also looking at whether or not they're affecting your 5-star and your QRPs and what effect it may have on your survey and which residents the surveyors are going to select when they come into the building. So all electronic is the simple answer to that question.
Yeah, good question. Looks like Kane just put another one in that he had got. What are some strategies SNF communities should consider to improve their quality measures and value-based purchasing?
Oh, I love this question. And it's one of the things I spend a lot of time talking with administrators or executive directors of nursing, is a lot of times what you see when you go into a community is everybody's holed up in a room in a meeting, right? Talking about their quality measures and their QAPI, and the people that really actually drive those quality measures aren't at the table. So your CNAs, your nurses, your housekeeping, maintenance, everybody that has eyes on those residents on a regular basis need to know what your quality measures are. They need to know what goals you're trying to hit, because if they don't, they don't know what they're working towards. You can give the what, you can give the number and say, oh, we're a 4-star. Well, what does that mean to a CNA on the floor, to the LPN that's pushing meds, to the dietary manager, whoever it may be in the community? If we all aren't rowing in the same direction towards those quality measures and not everybody understands the how and the why, we're never going to get there. If your CNAs don't understand that if we don't implement a good dementia management program where we're approaching residents differently and trying to reduce antipsychotic medications and trying to reduce behaviors that affect others, it's just not going to ring true. So my biggest strategy right out of the gate for communities is to bring everybody into that conversation somehow, some way, making sure the CNAs know, okay, we improved here. We improved in pressure ulcers, but we had way more falls with major injury, and let them be a part of solving the problem. You know, I think sometimes we box ourselves in and we silo ourselves in by thinking we're the only ones that can have ideas. I will tell you, the more I talk to CNAs and nurses on the floor, they're the ones down there in those trenches working in it every day. And if we don't include them in the problem solving, it's definitely not going to work, because they're the ones that are going to have to make it work. So making sure we're entertaining their ideas for those kind of things, even if it's decorating a walker or putting a sticker on a door or whatever it might be, there is no bad idea really when it comes to being able to improve those quality measures in that value-based purchasing, especially when it talks to rehospitalizations. And I will add too, around the value-based purchasing, which we know is expanding this year and next year, but most of it is around those rehospitalizations. And another piece I always say is housekeeping and maintenance, not clinical people, right? But I can tell you when a housekeeper or a maintenance person comes down to me and says, oh, Mr. Smith, he just hasn't looked good the last 2 days. That is a 911 for me to go down to that room and assess that resident, because they're not a clinician. And if they're noticing a change, most likely something is going on with that resident. So how do we catch that as early as possible and involve them in those conversations? Just because they don't have a clinical designation behind their name doesn't mean they don't have value in assessing those residents. So I'm a little passionate.
Those kind of those kind of things that are brought to our attention really make us concerned, because to your point, they're not clinicians. They're in the building. They're used to seeing, you know, Mrs. Smith at dinner or in her room or walking down the hallway. And so when they notice something's a little bit off, that's definitely sirens going off for us. So that was a good question.
Travis, can I call you out, my friend? Put you on the spot? Can I ask you what questions your teams or point paints your team's feeling on the therapy perspective, or?
Wow, thanks for that, Kane. Well, you know, at Good Samaritan, we actually have our own therapy department. So we do everything internal anyways, and we have our own MDS national campus gurus and go through the training. And so to Karen's point, she made a little bit ago, the conversation about the respiratory stuff. We literally just had training on that probably about 4 or 5 months ago on the MDS with all of our MDS people. We have monthly meetings on the MDS with our national campus folks. And so I feel as an organization, you know, in our, probably 60-70% of our business is skilled nursing. Actually, it's probably more than that, probably closer to 80%. So we have a whole support group in place that's tracking and monitoring and doing a lot of this stuff already, and trying to spearhead those efforts. But, you know, from therapy perspective, I think there's getting away from the rugs, also to Karen's point, has been a good thing for our industry as a whole. We're seeing a lot more person-centered and tailored therapies, as opposed to just, getting the minutes.
Very cool. Thank you, Travis. Any other questions? Any hands up? Yes, please, Greg.
So I just did strategic planning with a big group out of Florida. And their big thing as they were looking at income over in the future was more based on ancillary services and how they can increase that, because that really kind of was helping on the bottom line there. Now you're one portion of that in theory, but what can communities do to further improve the bottom line? What other things can they look at or add, whether it's supplemental to what you do, or I'm invited, there's some other kind of products that you can kind of, try to integrate, I guess, or stuff like that. What do you see in that communities can do, especially large communities where a little thing here and there adds up, pretty good amongst, 60 communities, say?
Sure. The first thing I would recommend is making sure that you have some kind of software that lays on top of your EMR to ensure, and I realize that's kind of, it touches a bunch of different things. And I know it's not necessarily ancillary per se, but when you're enhancing your bottom line, it means capturing everything that's out there that's appropriate for that resident. And one of the things that I've seen, and I've been, like I said, in the MDS world for over 20 years now, and I dealt with PointRight and now SHP and Telelogics and several other scrubbing softwares and other softwares, but we're human beings. So being able to have another set of eyes, and while the scrubber software is an upfront cost, you're going to pay for it by increasing that reimbursement, increasing your patient identification of being able to see when is that resident really starting to head downhill and catching it before it gets critical, where they're triggering your quality measures, where they're triggering other things and triggering on the state survey, where those surveyors are going to hone in on that specific resident. Can we catch those things earlier, which is a soft cost in some ways, but on the end is actually better for whether it's your QRPs, whether it's decreased in survey tags and fines, but then also improving your reimbursement. And as we move towards all states being PDPM for Medicaid, with the exception of a handful that are going to stay cost-based, having that level of oversight into your MDS process and that AI piece around that. I mean, we've shown for us in just 6 months, almost a $65,000 improvement in 2 sites just by using that kind of software. That's huge for these buildings, huge for them. Exactly. So it well pays for itself, even if it's a $500 a month software. It's still that step that puts that extra set of eyes with that MDS team, because they can't catch it all. They just can't. There's no way, especially with pieces of it being here and this is scanned in and this is typed in and the nurse didn't do this. I mean, there's lots of different scenarios I know that you guys are aware of, but that would be the big thing that I would highly recommend for anyone, even if you think you have the most perfect MDS coordinator and MDS process. If you don't have something else that's checking behind you, you're probably leaving a lot on the table.
That's really good. And then my last question, I'm an architect. I'm sorry, go ahead, Jesse. Do you want to go first, sir?
I was kind of to piggyback off what you asked, Greg. I wasn't sure when you were asking that for your operator that you're talking about, was that primarily a skilled SNF communities?
It's regular, all of the above, CCRCs primarily. So they have a lot of that stuff. Okay. So my last question is, I'm an architect, we do some planning and stuff, but we were focused a lot up to about the past 3 years ago on a lot of kind of medical resorts, a lot of rehab focused communities. So that was a large part of, especially doing the nursing. That's, fallen back a little bit because the benefits of having a large, full rehab suite and stuff like that is kind of, seems less, helpful, I guess you could say, with the current reimbursements. In addition, we were doing a lot of aquatic therapy stuff. So, we have one community that, the 3 pools, one outpatient, one inpatient, one that's more kind of a hybrid between independent living and physical therapy. So what are you seeing as far as if we are repositioning or doing a new community, as far as the physical therapy side of things, are you still seeing that they're going to get smaller? Are you seeing that there's other spaces that are really more important, that have, more benefits to having them, and any thoughts or recommendations you might have?
Yeah, and I think the industry over the last several years, especially during COVID, and I think it taught us something about therapy and some of the other services out there during COVID, is we don't need a big fancy gym. So I'm a speech therapist, so my equipment is really, really tiny.
One really nice
fact,
quiet room, yeah.
Mostly, yeah, it's mostly not, it's like spoons and cups and straws and things like that. So very portable. So very different from the new steps and the big, huge Nautilus gyms. And we've certainly challenged our therapy teams to focus more on that function, because when the resident goes back to their apartment or cottage or home or wherever it is, they don't have all this big equipment. So what do we do that focuses on that function, that maintains their ability to thrive in place for as long as they possibly can without all that fancy equipment? And I think sometimes marketing, and I'm going to point Chris out just because he's a BD guy, but for a sales guy, you know, when you have all these really pretty big pieces, hey, look what we have. Yeah, but then you walk in 3 months later and they're holding up coats and other equipment and TheraBand and not necessarily being used because they don't necessarily promote function. And we know as we've moved through the therapy world, and it, like I said, especially during the pandemic, making sure that we had that focus on function. Can they pick up a gallon of milk? Can they take their dog out and not trip over the leash? Can they lift their walker up into the minivan? Those kind of things that a piece of Nautilus equipment is never going to replace than actually doing those kind of things. So with that said, to answer your question of where do you think that's going, I think wellness is where it's at. Making sure that our residents can continue to thrive in place and growing that partnership between wellness and therapy. We have on our clinical team, we have our national director of health and wellness, and we want to be integrated from a therapy and a wellness perspective to be able to have good handoffs back and forth. It should never be one or the other. It should be both working in concert together, that, you know, therapy is going to a wellness class with the resident, or the wellness director is coming to that therapy class with that resident, whatever that looks like. But it's no longer about these big, huge, massive gyms. It's about keeping those residents thriving and aging in place for as long as possible through those functional treatments.
That's interesting, because wellness is a big thing, and now we're actually begin pushing longevity, right? Which is even a deeper dive into that. Is that something that you're expanding? How do you integrate and provide that wellness, I guess, integration? Because, you know, that's a little bit more into the IL-AL side. How are you doing that? That's awesome.
So one of the things that we do for us is we offer on move-in, and then every 6 months, what we call the functional fit test for our residents. They get a free coupon. It doesn't cost them anything, but it's really just having those eyes on the residents to see, are they having any changes? And I think it's a 6 or 7 part kind of assessment of the resident, where we look at their balance, we look at cognition, we look at their frail scale, which a lot of people don't do. You know, frailty is a huge indicator of falls and decline and those kind of things that we can mitigate. So looking at those kind of things as well, and making sure we're showing the residents where they fall on those scales, and then either making a recommendation to wellness classes or recommending them over to therapy. And what we're seeing is increased length of stay, where the resident is for that, but then also that initial assessment of the resident, so we can catch anything that maybe nobody was aware of before they came to us. And then making sure that we're providing either that therapy or wellness service to be able to promote that independence for as long as possible. And another piece around that too is around some of the caregiver education as well, and bringing, if you have a couple that moves in, and I'll use my parents as an example. My dad had dementia, and my mom needed some caregiver education on the wellness side. So she learned that there on that wellness piece to understand how to deal with a loved one who has a cognitive decline. It's about increasing the success for the caregiver and the loved one that caregiver is providing care for. So making sure that it's not just the wellness of the person that's attending, but the wellness of the person taking care of the person that's attending as well, if that makes sense.
It does. And when you do
Hey,
the
Greg,
assessment,
and sorry, Greg, I was just going to add, one other thing that we hear a lot of from our clients is just trying to create the CCRC without walls out in the community. And, from an architectural perspective, building kind of that outpatient gym space that has access to the outside, because they're always looking to get more people on campus, and how do they do that? And to Karen's point on wellness, I was meeting with a group in South Carolina a couple weeks ago, and one thing that they're doing is they're building a wellness gym. They realize that they don't have anything that draws the community in. So, I think from your perspective, those are things that we hear a lot of. How do we reach more people outside of the walls of the CCRC through outpatient or wellness or even therapy out in the home?
well, that's big. So when you do your assessment every 6 to 12 months, is that if you're in a nursing home, if you're in an AL, if you're in a CCRC, is that everybody in the full community?
Typically less in the skilled nursing facility because we're already running those through, and we have a separate process for them. We screen at least quarterly for our long-term care residents, but for the AL, IL, and the memory care residents, definitely putting them on a schedule. And sometimes it's sooner than 6 months, but definitely on move-in and at least every 6 months to keep eyes on those residents and make adjustments or recommendations wherever we need to.
That's awesome. And Chris, I'd love to talk a little bit more how to do that, because when we're planning communities, it'd be great if they would integrate that more and we could have a proven return on doing that. Because a lot of times we'll do it, but they won't really completely do it. And then you have to separate the outpatient typically from the inpatient in some communities. So it'd be cool to maybe dive into that a little bit and show the benefits, because that's where we're headed.
It is, and we've got a lot of clients that do it well, that they've come to us and said, hey, how can you guys help us do this the right way? We've talked to prospects that build this great outpatient gym, and it's like it's empty because they just really haven't thought through, all right, once we get the space, how are we going to market this, and how are we going to really attract folks to come in and do that? So I think, yeah, Greg, we can definitely get together and talk about some examples.
That's a total good people thing that we can kind of show our folks how they could do that well and find the folks. I got Kane going there. Sorry. Yeah.
Hey, I have a question for you, Karen, or you, Chris, as well. I saw a piece of equipment very recently. It's, I guess, kind of like a new step, but it's like a sit-down bicycle thing. Anyways, they're in putting in part of it, gamification of it, so this way the residents can kind of like see where they're at, assess maybe with other people their age. Is that something that you guys have seen? And is that something that I guess residents and older adults care about, or is the generation who's maybe more interested in the games still up and coming, like a ways away, or is that just beneficial?
I think it depends on the game, and I'll have Iran pipe in here too, because we've been doing some work with Restore and it's been really exciting. I think it's a mixed bag, but it has to be something that is not so crazy complicated that the senior population isn't going to get it. Like, they're not going to be able to sit down and play Halo, right? I can't sit down and play Halo. I can barely do Super Mario. So, but being able to do the slot machine and have those similar movements to that, I think we've seen that take off quite a bit in the last couple of years, again, especially through COVID, because they had increased screen time to be able to communicate with families and those kind of things. But again, remember, when it's associated with a bike or something like that, is that the most they can do is sit at a bike, or should they actually be up and testing their balance and doing other things? And my PT and OT counterparts will say, look, there's definitely a need out there for the new step or that kind of equipment where you're just getting like a patient with Parkinson's. They need that repetitive moment, right? They need to have that. For a patient with dementia, same thing. It's that rote movement, but that's more of the exception than the rule, and it shouldn't be your whole entire treatment. So it's not that I'm saying that you shouldn't have some of that equipment. I think there's certain patient populations where it's appropriate, but then there are other things where you really kind of have to push the boundaries. But I think from a VR and a technology perspective, I think the wave is coming, and we're seeing more and more engagement with our residents with that. I think most because they're seeing it in their grandkids and the caregivers around them as well. And they're still a very curious population. They still want to learn. They want to have purpose. They want to have all those things just like we all do. So I don't want to count them out just because they might be 90 years old. In fact, I have a neighbor that's 92 and she can fix my phone faster than I can. So I try not to count them out for that.
Can I jump in real quick? So before we go forward, I had a question about the scrubbers. That I heard big numbers in there and money to be made, money to be saved. Is there one that you guys functional prefers to work with? Is there one that's better than the others? Can you maybe speak to that a little bit?
Yeah, so there are three main ones that four actually, that I'm most familiar with, and that's SHP and Telelogics, Point Right, which is now up under Net Health, Real Time, and CareWatch. And I have worked most often with SHP and Point Right, and I'm learning more about Real Time, and it's actually pretty decent. But the best one out there right now, hands down, is SHP and Telelogics. Because they're actually adding an AI perspective to it, I believe in February or March, where you're not going to have to scan anything in. It's going to look through the entire medical record for you and actually be able to figure out if it's an active diagnosis or not, or if it's something that we need to include from a medication, all those kind of things. And it has the scrubber piece, but then it also gives you the opportunity to look at residents at risk, the 5-star, and being able to toggle to see how many points you need by quality measure to see when you can change your star rating. And then it'll also give you a list of residents every time you submit an MDS or do anything with the resident that will tell you, ooh, you better get this chart ready because the state's going to look at this when they walk in, kind of thing. So just ensuring that you've got all of those pieces. It also has a Medicaid piece that they're expanding as well as each state moves and makes their decision on what they're going to do with their payment, whether it's going to be PDPM or cost reporting. So there's pieces of that too. And the best part about it is so user friendly. Like I think I could drop my 5-year-old neighbor into it and he could probably figure out where he needed to go on it if I asked him a specific question. It's very, very intuitive. So that would be my recommendation.
Okay, great. And those work well with other electronic medical records, the top two, they work with all the top medical records?
Matrix and PCC, as well as AHT, although AHT is a little bit more challenging for everyone. I'm not sure how much, do any of you guys use AHT? I think it'll be an obsolete system at some point, just because it's pretty antiquated. Good information in there, no doubt, but it was built in a very different time. But yes, very integratable with Matrix and PCC. Like no blips in the radar, and it's simple, easy to use for your MDS coordinators. It lays right on top of your EMR, like you don't even notice it. And MDS, all they have to do is click scrub, and they don't even necessarily know that it goes to SHP.
Yeah, and Kane, we're partnered with a few of our clients using that, and you know the monthly fee is not all that much, but the return that they get, you know, and the financial pieces that they get through things that they pick up more than pays for the system. So it's really, you know, I would say cost neutral, but it's not cost neutral. They spend a little money and they make a little bit more because of it.
Yep.
Makes sense. Makes sense. Well, I've got another one here, and this is a bit of a shameless plug, but it's also a Functional Pathways sponsored shameless plug. So I'm about to go, and this is probably a good question for both of you, and maybe Greg, Jesse, Travis, Wayne, Aaron, nice to meet you, Meg, but we're about to go and travel to, looks like South Dakota, the Dakotas, to see Travis and all of our good friends, operators who are supporters of Team Good People. And we're calling it Moving with Kane. And I'm going to go to different communities and travel and hang out with the seniors in their communities. The first one we're going to is here in Tempe, Arizona. And they've built a rooftop pickleball court. So I'm going to go there and play the national senior champion of the North America, and he's going to give me a whooping at pickleball. And we're going to promote and highlight the community. So I know pickleball is a big fad these days, and I've been hearing a lot of different things about putting greens going in left and right, which I love that. But any other fads that you guys are hearing for active seniors across the country and ways that therapy companies are getting resident engagement and getting seniors active?
Dance.
Oh gosh, so I would say golf is up there too. There's golf, there are lots of golf simulators out there, but being able to get out and do the putting green, but more than just the putting, actually swinging. But it warms my heart to hear pickleball. My dad actually started the pickleball craze in Pennsylvania after going to the villages for years and taught me how to play. And now there's pickleball courts all over their senior living community. So pretty exciting stuff. But I think it's just a matter of making sure that the therapy team understands the needs and the wants of the residents in that community, and that we embrace that and utilize those treatment strategies in our sessions. It should not be just about doing weights and doing, leg lifts and those kind of things. It should be, again, ensuring that resident can thrive in place with whatever activity it is that they're doing. So are we going out to the pickleball court with them and seeing how their balance is or their strength is, so that we can work on those things from a therapy perspective and give the most appropriate exercises for them to continue to do what they love to do. So I think it really is about challenging your therapy team to be creative, to be innovative, to think outside the box and really practice at the top of their license, and not just do the routine things in therapy, because that's not what we're about.
Guys, I was just challenged. We're gonna put developing a pickleball game for the team for this year.
I'll test it for you, Ron. Be happy to test it. I love pickleball.
We are going to do the annual Good People Pickleball Tournament, right, Kane? We just talked about that yesterday.
We did just talk about that yesterday. I've had a couple of people come to me with that thought as soon as I brought the moving with Kane idea concept to light. And then I realized, as I was going through my friends, buddies that are running communities, that not everybody has a pickleball court yet. So I'm thinking maybe 2025 we'll do the pickleball tournament and set up a tour, and Chris and I will be a team, and we're going to dominate.
There you go.
Even
So
if
are
they don't
you
have
guys-
a pickleball court, if they have a flat area of a parking lot
We
or
can
a
set
tennis
up
court, just modify the tennis court that they have at the local park or whatever it is. There's lots of ways to play pickleball. I have a portable one that has the little rubber corners, and I can play anywhere I want to go.
I have one in my driveway. I have it marked off. I have perfect singles in my driveway, and everybody comes over. We have a ball playing it. So it's pretty fun.
Active. I love it. So real quick, any more questions? And then I thought if we have 5 minutes, we might just go around the room and introduce ourselves, since we're all here. Any more questions though for the professionals before we?
Hey, professionals, that's a little loose, I mean, Karen's a professional. I don't know if I fall into that category.
I would
You're
agree
a
with that
professional
statement.
sales guy. Come on, you can be a professional at anything, man.
That's
So
right.
in the as the conversation goes with wellness, and is there anything else that like functional pathways does or ties in? For instance, like with Wayne, like with food, when someone's under treatment or getting any advice for wellness, is there any specific like dietary changes that is coordinated throughout the community to work on that, or is that primarily left up to each individual and hey, here's what you should do, but it's up to you? And then
Well, one of the
Good
things that
question.
we've talked to our communities about that we've partnered with is there a trend in this community? Do we have a high percentage of people with diabetes? Do we have a high percentage of people with heart disease? Those kind of things. And then really gearing our lectures and our classes around that to involve maybe the dietitian that comes over from the SNF or the chef that comes in from the CCRC, to really pinpoint it towards those populations or whatever the residents are requesting. I think it's important to pull the residents too, especially for those that maybe now live alone and they're not getting the regular 3 meals per day that they used to get, or they're not eating the same, or their social economic status has changed, so they don't have access to the same kinds of foods. So really being able to offer those kind of conversations. I know for my mom, they have this thing in their community called the Katie, and it's this little communication thing. And I think most communities have those, where she has to check in every single day, but they have her medication list. So they actually make recommendations specific to her on on, hey, we know you've got this, 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 and this. Maybe consider this for your selection at the harvest table today, which is their lunch place. So just different ways to do that. But yes, from a wellness perspective, we do incorporate the dietary and nutrition throughout our different lectures, throughout the different classes and those kind of things. And we work with, whether it's the speech pathologist, if there are any concerns around diet texture changes, and then OT for getting it from the plate to the mouth. But then the dietary recommendations also.
And are you guys doing any coaching? Have you guys kind of gone back, kind of lean more into the IO wellness preventative stuff where, you know, because that's not reimbursement driven as much, but how do you, is there a way for you guys to integrate more on that side of things? Or, because I think that's kind of what's lacking to a certain extent. Everybody kind of does that a little bit different. There's really not a defined, successful, proven way to do that, which is the huge opportunity. Are you guys looking at ways to do that? And if so, I guess, how do you do it? How do you bill for it? And how do you kind of coordinate that effort?
I think that's where our functional fit test comes in, is really being able to engage our IL residents to ensure that they stay at a certain level, you know, that they come in and they're healthy and, hey, I want to stay living in my cottage, or I want to stay living in my apartment. Here's what I need to do to be able to do that. So therapy and wellness are going to be this handoff back and forth, and different communities bill wellness differently. We certainly have a structure in one of our tiers where we charge for the lectures or the classes or those kind of things, and the resident pays $10 or whatever it is. But then there's a referral process back to therapy as well. So that whole Part B, managed fee, whatever that is, will benefit that therapy department as well from a revenue perspective. And then if we're sharing that cost from therapy, but that functional fit test is huge. And then prehab is another thing for those IL residents. Are we doing the prehab that we should for those surgeries? And I'm not talking about just joint and heart surgeries. Any surgery that they have to go to when you're above 65, anesthesia is a bad thing for our bodies after 65, actually after 55, but it gets worse as we age, right? So making sure that we're having the conversations with the local physicians and saying, okay, can we have them in therapy, even if it's just for a week, to give them some strategies to do to counteract what they're going to see after they have that surgery, even if it's just a small one. Being down for a short period of time, it only takes 24 hours of being still for your muscles to start breaking down. So getting in there on that prehab piece is huge.
Gotcha. And does anybody have any coaching or anything like that, or is that just really individualized per community? Be interesting to see as AI gets more developed, right? That kind of creates a lot of that coaching reinforcement, kind of a little bit more of a, you know, weekly almost, as opposed to the whatever. Where do you see that being something that gets integrated in the long run, or something that you guys or the therapy companies are looking at trying to figure out another revenue stream or another ability to benefit the residents?
Yeah, I think IL is going to be huge coming down the pike, and just senior housing in general that isn't necessarily associated.
Active adult too, right? That's even,
Right.
Ironically, yeah.
And I really think it's just about that resident identification and person identification. I think people are afraid to tell people that they're maybe not doing as well as they used to. So what is that? One of the things that we're working on is kind of that self-assessment. If you don't want to come see us, at least assess yourself.
That's cool.
And if it shows, typically it'll scare them a little bit, which I hate to say it that way, but hopefully you know what I mean.
Encourage them, yeah.
Where it encourages them a lot to go out and seek other things, even if it's just a wellness class, even if it's just going to Tai Chi or to pickleball or to line dancing, whatever it is, at least it's another set of eyes on that resident to help them age in place as best as possible. But I think self-assessment is huge.
Perfect.
It just a couple notes on that, not necessarily related to my current role, but in a previous role working for a provider that most of you will know, Mather in Chicago, we took a shot at this whole wellness coaching concept and did a lot of research over several years around it. And the bottom line, which probably doesn't surprise this group, was it's just really hard to get people to pay for it and to monetize it in such a way that it becomes beneficial to the owner, if you will, or the sponsor. And so, now that I've moved to my current role and working for a food service company, I mean, we have more tools probably than most of our providers, clients and residents will ever use. But I will say that I have seen an uptick in interest. I have seen more engagement around not just, I go sit and listen to somebody, speak for 20 or 30 minutes. There's more question, there's more interaction, there's more interest. I think as the younger population, the younger boomers get into our communities, to your point, Jesse, I think there will be more of that. And I think it does tie to not just sitting and listening, but getting engaged, especially at the independent resident level, obviously, but getting engaged in the meal prep and having people not just come and passively participate in a meal, but actually be active in it. And I think that's where we're seeing some changes in some of the more progressive providers.
And Wayne, to your point, I feel like that's where things are going to have to go eventually, because like it's that age kind of separation. I feel like in the past and previous generations, and even ours, like mine, like we know that there's no money in wellness. I mean, there's money in wellness now. Like people are like, it's wellness. People are buying hand over fist for wellness. But even up to like 10, 15 years ago, there was no money in wellness. It's all in the medicine and just prolong and just deal with it.
Yeah.
I had very slightly elevated like cholesterol levels. Like I'm talking like within 4 points of the median to high. And the call that I got from the doctor's office was, hey, we noticed your levels were a little high. We're going to put you on this drug to help. And my wife, who's a nurse, she heard me on the phone and she's like, she went off. She put it on speakerphone. She's like, there was no conversation about diet change. There's no conversation about health. There's absolutely nothing. And you're going to put someone on a statin drug for the rest of their lives. It's like, this is absolutely insane. And I feel like it's only now, like the conversations are happening about, look at all the adverse side effects from all the drugs that we've been taking forever. And it's because, the country we're in, majority of people would rather, you know what, let me just I have high cholesterol, let me take a pill. This way my cholesterol is not so high and I keep eating whatever I want to eat and I don't care. Like no one wants to change anything. So wellness is coming. It has to force change.
Moving with Kane, sponsored by Functional Pathways, coming to a community near you, Jesse. So thank you, everybody. I know Karen, I know how busy your schedule is. I don't want to keep you over.
I appreciate the time.
Thank you.
Ron, thanks for the shirt. I'm digging the FP shirt, man. I love it.
Well, my pleasure.
Hey, Ron, thank you for joining us. I look forward to chatting with you and getting to meet you. Wayne, nice to see you. Jesse.
Good to see everybody. Happy New
Thanks,
Year.
everybody.
Thank you, Meg.
Thanks, Kane.
Good to see you guys.
Thanks for joining us, guys.
Talk soon, everybody.
See ya.
Bye-bye.
Hey, Chris, are you going to be at Asha? Oh, never mind.